So look, with regards some of the comments that Tim made there, I have to wholeheartedly agree, in particular with regards to the settings and where we are in the settings. The tsunami that's coming over the hill, and the question is, we're looking in a lot in the conversations we're having, and it's great to have Professor Patrick Jeurissen here today, who's going to maybe give us an external perspective. And I love the title that he has on it, particularly the sustainable bit. Patrick actually is a full professor of sustainable healthcare systems in Rotterdam University Medical School and is the science officer for the Ministry for Health, Welfare and Sport in the Netherlands. He has extensive experience across the board. He's an expert in design and implementation of policies that specifically address issues of sustainability and affordability in healthcare. Very appropriate for today's conversation, that's for sure. He has co-authored up to 75 publications and is a sought-after speaker. Patrick represents the Dutch government in the OECD and the EU on the sustainability of healthcare and has been a consultant to the WHO on these issues. His major interests are specific policy, strategic policy, healthcare finance, and cost containment policies, etc. Without further ado, I'd like to welcome Patrick to the podium.
Hello, everybody. Good to be here. I'll try to keep my talk a little bit briefly, maybe to save up some time. I want to basically discuss three things, but I need to warn that I'm not sure if we'll be able to reach the last one. So I want to talk a little bit of what makes a healthcare sustainable, what are the Dutch experience in that context, and then if there is still some more time, we can go into the role of the private sector in all these things. Now, the Dutch healthcare is basically a kind of a puzzle, I guess. I mean, when I came in here yesterday, many people were asking me, what about the cost of the Dutch healthcare system? It's very expensive, right? I guess it is, but I'll go into that a little bit later. At the same time, the system topped a ranking of the European Health Consumer Index for the last 7 years. Topped a recent EU study of the most efficient systems in Europe, together with Cyprus, by the way. I don't know what that means, but and will top again a US Commonwealth Fund survey in 2 years from now. So that seems to be okay if you believe in these things, and at the same time it is quite expensive, but it has its reasons. So I think, just to keep it very briefly, what makes a healthcare system sustainably? Well, basically it's about, of course, access, quality, efficiency. All these things. I mean, and you can debate them. If you look at the Netherlands, basically access, I think, is its main performance. We also know that despite all these rankings, there are not really that many golden bullets. At least the OECD say so. Personally, I think what's all about is, can you innovate along the lines of value and efficiency? And so that's one part. And the other part is, can you correct things that go wrong? And for example, if you look at other countries, and I think we saw some real nice examples this morning, you see the US seems to be very good at innovating across the country. And at the same time, from my perspective, the system doesn't seem, to correct value-destroying behavior, which is there as well, think frauds, things like that. So I think it's also always the balance between those things. You need to innovate. If you don't innovate, it will not become sustainable. And at the same time, the governance mechanism needs to be able to correct if things go wrong. And that's basically one of the main points I would address today. So I got this slide. It's very difficult actually to make a slide of a healthcare system. I tried to put it on one slide, but just tell you a couple of things of the Dutch system which you must know actually. The first thing is it's like totally private. So there are no public hospitals, there are no public insurance companies. It's basically totally private. 95% of that would be like non-profit private. Most for-profit private will actually be forbidden actually. And it's very unique and very typical of that model. So you should remember that it's totally private. It's has strong primary care system with gatekeepers. Most physicians are self-employed, not all of them, but most are. At least 70% will be typically self-employed, also in the hospitals. And risk solidarity is among its core values. More risk solidarity than income solidarity, actually. And then around 20 years ago, these thoughts were coming around of, a new system which should basically be based on universal access on the one hand and competition on the other hand. Now, of course, you can see the political compromise being like right-wing parties going for the competition side, the left-wing parties going for the universal access side. So how does it work? It's like a circle, at least I would, see it as a circle. And the circle should like guarantee universal access on the one hand and also increase productivity on the other hand. So we start, with a system which is open enrollment, so you can go to every insurance company you like, and they have to accept you. Universal coverage, of course, for certain benefits, for most benefits actually, and the insurance companies need to use community rating, meaning they charge everybody the same rate, although it's deductible. And then the idea is that these insurance companies, that they will compete for a number of patients, or insured people actually, and release. So we have a very sophisticated system of risk adjustment. That's why the diabetes case, which was mentioned by the former speaker, for example, which is more or less able to predict around 98, 97% of future expenses, future claims. But of course, you don't want an insurance company to go broke, so we also have like solvency setting rates by the Dutch Central Bank, etc. But the idea is that these companies compete. Then in the end, they can compete, on their own overhead and stuff, but, in the end, that means they need to help to improve care. That's the idea, right? So for that, there should be something like selective purchasing, free setting of rates, a quality indicator so that they contract on the basis of quality. This is all the idea. I will just, tell the results of 10 years in a minute. So this is what they have to do. And then they contract the providers who also have, actually, we don't have certificate of need regulations anymore. Most of them are sorry, I would say most of them are like non-profits. I already told that. And they can be like contractions. It's important to notice that it's also like a political compromise. On the one hand, our law says there's freedom of choice for everybody who is born in the Netherlands. And on the other hand, the same law says, oh no, insurers should, do like selective purchasing. So that's been settled by the judges. They basically agreed that a co-payment of up to 20% will be considered freedom of choice, even if there's no contract. Which means that if you are a healthcare provider and you don't have a contract with the insurance company, you can still be reimbursed, but only up to 80%. Now, then the idea is that these providers also compete, and for that they innovate. That's the idea. And because of the innovation, there will be higher productivity. So the innovation, the improvement of the system is, I think, one part of the sustainability part, and the other one is in the middle, and I didn't draw it on the beginning or the end. It's all the governance what's there. Many agencies, stuff, public, private, who basically their need is to correct things if things are not going to go right. For example, if providers will merge too much, a competition authority needs to intervene. And so we have all kinds of, but the idea is basically, and I think that's the other one which you really need in sustainability, that there is like a governance mechanism which is able to correct things that go wrong. So that's basically how it works. Now it's implemented step by step. That's the way we do it. And you see actually on the bars, the blue bars, you see what's actually the level of risk. It's much more complicated than that, but the point here is that the underwriting risk for payers have gone up, and that we had a step-by-step approach, and that 2012 was like a big leap forward. And 2012 is kind of an important year in our history of health reforms. And you see over there that 2012, 91% of the money was actually at risk. So without any public reinsurance or equalization scheme. And it went up quite, drastically in that year. The level of risk also went up for patients, especially the deductible, but also the number of patients who choose for supplementary insurance declined, and the number of patients who choose for like a network policy, so with more stiff limitations, increased, and also the number of people who chose for like a voluntary deductible, you can choose for a voluntary deductible of up to 500 euros, also increased. So in 2012, we basically see that the level of risk from the payer side, from the provider side, but also from the patient side and the side of enrollees increased. So now we have 4 years on, with more or less 4 years, this system being like full into the open waters, and safety nets have gone and not really that more anymore. So, what are its results? The number of uninsured declined from around 200,000 to around 20,000. So we live with 17 million people and around 20,000 are uninsured, which is, I guess, not much if you consider that's like a private system, so you have to get your insurance. You will not be automatically insured or not, so you have to go out and get your insurance, and we have 20,000 people who are not insured anymore. The switching rates are around 7%, which I would argue is around right. You don't want 50% of the people switch their health insurance every year because the system will become unstable, and you don't want to switch 1% also because then nothing really much would happen. We have around 7. Now, if you look at the premiums up to now, I mean, the predictions for the next year are a little bit different, but premiums have declined. In 2012, that was this year, which I was talking about, the average flat rate premium would be 1,226 euros, and 2016 it was 1,203. Of course, the deductible got up, so that explains part of it, but also the number of benefits was increased quite drastically. So actually, from the perspective of the people, although they might argue otherwise, because if you get the bill, you might still think it's a lot, but you see actually there's flat rates, that rates haven't gone up for the last 4 years, which I think is quite remarkable. At the same time, and that's important if you look at the fiscal perspective, you see that although the system, is not really cheap, and it increases also a bit of the cost, but that the solvency level of both the payers and providers also gone up quite drastically. So there is much of money flowing around in the system, which has been built up over the last decade during those reforms, and it will be around, I think a rough guess would be like 25 billion euros. And that actually gives us quite a bit of resilience if there is like more austerity or stuff coming on down, because there is money available, for example, to prevent waiting lists. And that's, you don't see these in any statistic, not in any official government statistic or in a statistic of the EU or a statistic of the OECD, but it's there. And an economist would argue that, that compares with efficiency gains. The overhead of the insurance companies declined from around 4.5% of the former sickness funds, private insurers would charge something like 10%, to around 3% currently. So the claim ratio of the insurance companies is really above 95%. And 5% will be for their own administrative expenses, and they have profits of around 1-2%. Which is, I think, also quite good. I mean, if you consider that, I think in Obamacare, there's like this legislation that an insurance company should spend at least 80%. So 20% is spent probably on other things, and yeah, we do like 95. So I think that's good. The selective purchasing is actually one of the drawbacks. I mean, there is some, but basically we see few changes in provider market share. And one of the ideas is that money will flow from, say, bad providers towards better performing providers. And that means that, you would expect changes in market share. There are some, but not that much actually. On the provider side, we see the same. We see a stiff increase in solvency. We see that prices are rather flat, but we do see some mergers until actually quite recently, because the competition authorities now became much more stiff. Now on the innovation, you have of course all kind of innovation, technological innovations, and I'm not going into that, but I give you a couple of figures, the number of new providers that entered the system in the last 10 years ago. So we didn't really have a history of independent treatment centers or ambulatory surgery centers, and they increased like for 600% in the last 10 years. Now you can say I don't like it or it's bad or anything, but at least it means that the healthcare delivery system is changing quite rapidly and quite drastically, so there's some kind of innovations. Hospitals are building outpatient clinics all over the place, which they didn't really did before. We have around 80 hospitals, and they now together have around 120 outpatient clinics. Now the productivity of all that we measure, and it is of course very difficult to measure productivity in health, but we measure annual productivity of around 2.5% in the hospital sector. Outputs divided by inputs. And for example, average length of stay, which is like a rough indicator, declined from 8 days in 2002 till 4.7 in one of the most recent estimates, which is more rapidly than in other OECD countries. And the waiting lists, which we also have a huge waiting list in 2000, they're vanished, and they're still not really to see. Now, to end it up, what does that tell us about fiscal sustainability? And I want to make like a couple of final points for that. You should look at the blue bars on your right-hand side. These are the levels of overspending on the healthcare budgets and underspending. And a blue bar up means overspending. Now we overspend our healthcare budget with around 30 billion euros in the period from 1994 until 2012. That's what those blue bars say. So overspending. I mean, I used to make the joke to the colleagues of the Ministry of Finance that we beat them every time because they couldn't really get the money back. But the money was 1,600 euros on overspending, so on top of rising expenses, for every Dutch citizen, 1,600 euros. And starting in 2012, and we've never witnessed this actually, there is underspending. Now, I don't say it's going to last, but we never witnessed underspending. I mean, the money is there, people can spend it, but it's not being spent, So some countervailing powers are holding things back. And the underspending, which is for the last 3-4 years around 5 billion euros, the underspending is around 400 euros for an average Dutch family. And that also explains why the premiums are, rather flat. Which is the top set. I mean, this is really explaining, in my view, why there is really competition on the insurance market. We have like an official forecast of the premium, which is very important politically because it's one of the main determinants of purchasing power in the upcoming year. So if the ministry has a low forecast, it means, on paper, people have more money freely to spend in the upcoming year. So it's politically a very important figure. And you would expect us to give a low forecast, and we often do. And so we do things like we expect insurers, to free up their solvency and to give back money to clients. But what you see in this slide is that except for 2 years, which around 14 euros, the insurance companies always beat our forecast. So, I mean, they always set a lower premium than we expected. So from my perspective, I mean, that would be like sustainable. At least it means there's some competition. And you also see the growing solvency levels of the providers. Now, to give like 6 more seconds, so what does that brings us? Not to the private sector, so I skipped that part of the presentation. But it brings us actually, I would say, like with 3 conclusions. I would argue that the system is fiscally sustainable, not because costs will not rise, they will rise, but because we are below what politicians want us to spend on healthcare. And there's a lot of money into the system, which is efficiency. On the side of quality and patience and innovations, many things have been done. Not all things are right, but at least there are changes, and the main challenge is can you support the good innovations and stop the worst ones. So my final thought would be that, from my perspective, the system has become more sustainable over the years, especially when it's now going into open waters. And to give a final line on that one, we used to have like the 2nd highest expenses after the US, but now new OECD calculations turn us up at 7th. So we're like declining in that line, which is basically being the performance of the last years. So I leave it with that. Thank you.